She is an assistant professor of urology and is an expert in the management of a wide variety of urologic conditions, including minimally invasive and modern techniques for approaching all the conditions you see listed here. She obtained her medical degree at USC and completed her internship and residency at LA County before coming to New York for her fellowships at Memorial Sloan Kettering and Weill Cornell. She's distinguished herself here at Sinai as an educator, as a surgeon educator, as the associate program director of the Urology Residency Program, but also in my brief experience with her as an educator of surgeons. I had the fortunate experience of attending the GME conference last year, and she has spoken really nicely about teaching in the operating room and how we train our residents. And I think we have a lot to learn from her experience and the way she presents that. And so welcome.
Thank you so much for that introduction. Let me see if I can share my screen. Can everybody see my screen?
We can.
Let me see if I can do the presentation mode. Oh, hold on. Hold on a second, sorry. Is this acceptable, I think? Yes?
Yeah, I think that's fine.
All right. Sorry, having technical difficulties. So let me go back. All right, so my talk, thank you for having me today. My talk is entitled Teaching in the Operating Room. What are we seeing, what are we doing, and what are we teaching, and how can we make it better? I have no financial disclosures. So as mentioned in my introduction, I was invited to speak about surgical resident education in the learning environment. Some objectives that I put together for the next 45 minutes or so this morning are the following. So number one, I want to give everyone an idea of how to create a supportive learning environment or an optimal learning environment. And I hope to help everyone understand how important and vital it is to have this environment for learning to occur. The second point that I wanted to review was how ways that we can engage our learner. As with last year, we've all had to change the way we teach and the way we learn over Zoom, for example. And with that change in format, we've had to deliver our content differently as well. And the third objective is to demonstrate that feedback is essential, and it's an essential component to learning, especially in medical education. Over the last several years in medical education, there's been a big emphasis on feedback, and hopefully I'll show you why we have to give feedback, and hopefully through this talk, I can show you how we can give effective and constructive feedback. As you can imagine, you can dedicate a whole hour or conduct an interactive workshop for each of these topics, but I'm going to try to run through them very quickly. So, why do we need to essentially teach teaching? To put very simply, we can be better. So I'm aware that, I'm talking to an audience that has various levels, skills, and interests in teaching. Some of you have been doing this for decades, and some may have just started. And I actually sat into your morning, the 7 a.m. conference, and I actually really enjoyed Chris and the way he spoke to the residents and the way he taught. And hopefully through my talk, I can point out some great things that he did. And he really did a lot of great things. The second thing is work-life balance. We have limited work hours, and we have to ensure that our residents and medical students learn as much as they can every day. However, few of us, as very busy surgeons, have not been formally taught to teach. And that's okay. That's why we have continuing medical education and faculty development. So what do educational encounters for surgeons look like? Here are some examples of where education can happen. It can basically happen anywhere, right? So it can happen in the operating room or in the team room, conference room, huddled over computers. Did anybody think about the scrub sink? So as anesthesia was putting a patient to sleep, our team would be huddled outside reviewing parts of the case, deciding who was going to do what, anticipating which parts were going to be difficult. So again, just a reminder that educational encounters happen all the time. So for surgeons especially, in contrast to our medicine colleagues, almost all of these educational encounters are brief, spontaneous, and opportunistic. When you're in a surgical situation, we're doing multiple things at the same time. Not only are we progressing through a case, anticipating the next moves, the next instruments, teaching residents and medical students, we're also frequently interrupted. It could be something unexpected that we see that happens during the course of the surgery, or we need to stop and ask for an instrument or a change of direction. So again, this is in contrast to medicine rounds where an entire team can sit in a nice room and discuss hyponatremia for 3 hours. So teaching like the Suez Canal is very important. It's an important commitment for academic surgeons alongside the duties of patient care, research, and continuing professional development. But very often we as educators encounter barriers to teaching. Does anyone have any ideas for what are some barriers to teaching? What stops you from teaching your residents during the clinical day? So barriers to teaching can be categorized into the following groups. Could be physician related. For example, if you yourself are learning a new technique, it can be hard for you to teach it. It could also be a lack of comfort in teaching because you don't quite know how to teach something. And also there's a desire to move the case along or to finish rounding quickly. We want to get everybody home. We want to get the patient off the table. Some examples of systems issues are the demand for increased patient volumes. Also the need for documentation, which can be time consuming and can unfortunately take precedence over teaching. As mentioned over and over again, and kind of a theme, time is a big limitation. We have concerns over work violations, limited work days, conferences, all the things that we think of that are competing for our time. Another possible barrier may be patient related. If you're involved in a trauma situation, you have to work fast and there's no time to formally teach. Maybe we can even consider that learners themselves can be barriers. Maybe you have an intern on a rotation who has no interest in neurosurgery, or in a more common scenario, maybe you have 3 medical students, a junior resident, a chief resident, and they're all at different levels and have different educational needs. So this is a quote from Albert Einstein. "I never teach my pupils. I only attempt to provide the conditions in which they can learn." Does everybody agree with the statement? Well, I think he's talking about the learning environment. So this is a simple model to show the components of the learning environment developed by the Stanford Faculty Development Program. I actually attended a 2-day workshop through the GME office on how to optimize the learning environment. And I found this very helpful, and I actually brought it back and presented it here to members of the Mount Sinai community. As with all complex surgeries, the learning environment can be broken down into smaller components. So you have the teacher, which can be an attending fellow. You have the learner, which can be a resident or medical student, and both interact with each other as demonstrated by the blue arrows. Then we have the content, and that could be any subject matter. And for this group, you're the experts on the content of neurosurgical training. So I have no suggestions to give for the red circle. And the most important thing is the context here in blue. So in the medical education community, we've been talking a lot learning environment, but what does that really mean? And why don't we talk a little bit about that? So there are 4 key components and teaching behaviors that are key to optimizing the learning environment. The first one is stimulation. The second one is learner involvement. Then there's respect and comfort and admission of limitations. We'll quickly review each of these components, starting with stimulation. So show enthusiasm for your topic. I love arteriovenous fistulae. I'm so excited to be here at Grand Rounds. I love having medical students with me in the operating room. Show your interest through body language. Look at your learners. If they're hiding in the corner of the OR, invite them to come to the table, of course, when it's appropriate, and make sure that they're sterile. use an animated voice. So for this morning, I drank an extra cup of coffee just so I can keep everybody interested. Try to provide a conducive learning environment. For example, during our robotic cases, make sure your learners can see the monitor, invite them to bring chairs so they can sit and watch what is happening in the operating room. If you're giving a Zoom lecture, try to break up the lecture into digestible parts and add lots and lots of pictures. So that's how you combat natural decrement in attention. So I'm going to skip learner involvement for now because there's a couple of slides that have that on that topic later on. And we're going to briefly talk about respect and comfort. So get to know your learners if you can. And as our first speaker, Chris, had demonstrated, he knew all of the residents' names. He asked really great questions. So, if you happen to have a resident who had a pretty bad call night, they're up all night and they're in your operating room and they're really tired, it can go a long way to acknowledge that, post-call days can be tough. I'm sorry you had a rough night. Some medical students feel bad if they come to your operating room and they have to leave for a class and, they kind of sheepishly say, oh, I have to go. But, tell them that's okay. It's all right for them to leave. And, you're welcome to come back to the operating room and, pick up just where we left off. It definitely helps when you show respect and comfort to your learners. So an example of a suboptimal learning environment is, this cartoon right here. There's no such thing as a stupid question. And this cartoon depicts what we do not want to do, which is creating a hostile learning environment. So the last part of optimizing the learning environment is admission of limitations. And admittedly, for me, this is a little difficult concept for me to grasp, but it's basically showing grace and role modeling professionalism to your learners. For example, when you're in a technically difficult case, you want to let the resident keep operating, but, because of patient safety issues and maybe they're not technically there yet, you have to take the case away from them and you just let them know, what, this is kind of a tough case. I'm going to give it over to the chief. So again, expressing that, their limitations to what we can teach and what we can do to the operating room in the operating room, again, goes a long way. Another example is, you have a medical student closing an incision and it takes a really, really long time. Sometimes it might be better to kind of set the stage and say, okay, I'm going to let you start the incision, but I'm going to have the chief or another resident finish just so we can at least give them a little bit of experience, but move the case along. There are many things that we have to balance in medical education. So I wanted to show this picture, which is a review from Expert Teachers published in 2019 by Jaff et al. And it's a different way to express how we as teachers can establish a learning climate. And I like this because there's a nice umbrella and we're setting the atmosphere. And some things that you can see in the picture is, there's ground rules, there's trust, it's a safe space to be wrong, and showing respect and empathy. So the storm clouds, as you can see, is just a different depiction of the challenges and barriers that we have discussed earlier. So going back to our objectives of optimizing the learning environment, now we're going to discuss how to actively engage the learner and then how we can provide constructive feedback. So does anybody know what the most effective way to learn is? Is it listening to a podcast, reading textbooks, watching a movie, drawing, writing a manuscript, making an outline, talking it over with another person? It's actually all of the above. So this is Culp's Experiential Learning Cycle, which was published in 1984. David Culp is an American educational theorist and a cognitive psychologist who believed that effective learning occurs when a person travels through the cycle of all four of these stages. So number one, starting off with the purple here, having a concrete experience followed by observation or reflection of that experience in green, which then leads to a formation of abstract concepts. We're able to have an analysis, which is here in orange, and then which is then used to treat and formulate a hypothesis in future situations, resulting in new experiences. So we constantly, his theory is that we constantly cycle through these four moments. So in 1986, Peter Honey and Alan Mumford actually built upon Culp's learning cycle and created types of learning styles. And we can discuss each of these. So number one, activists, which I believe most surgeons are. Usually we like to get on with it and do things. We don't like theorizing or thinking for too long. There's also reflectors. They don't like to be thrown into an activity right away. They like to think and observe and review. And, I built into this talk questions that you can ask yourself. Some things that reflectors probably don't like are direct questioning. So sometimes when you're doing a lecture, for example, maybe these types of learners don't like, being asked directly a question because they might need some time to think about it first. Theorists, these types of learning styles are always asking why. They like clarity, they like logic, they just want to understand everything. Pragmatists want to focus on the here and now, and they don't like endless discussion. They like planning and putting things in place, and putting things into practice. And as you can see throughout my talk, I put in moments where we kind of circle back and go back to the objectives. So pragmatists love objectives. They love knowing, okay, what am I doing? Why am I doing it? How long am I doing it for? So they're very, very practical. So here is another picture of Culp Cycle. So again, I don't want to mislead anybody. It's not like each person, there's one specific style. Each person tends towards one style, learning style preference. You can actually, have a little bit of both. And the most effective learning style, at least from their theory, is that it's an intersection of all four quadrants of this model. So using observation, conceptualization, repetitive action, and hands-on experience. So now that the weather is getting warmer, a good example is swimming, right? Hopefully everyone will get a chance to go and swim this summer. So do you remember how you first learned to swim? Did you jump right in like the activist? Did you read about it first like the theorist? Maybe you just thought about it and watched people like the reflector, or did you just jump in like the pragmatist and you just threw on some goggles and just jumped in? So again, everybody has a little bit of everything. And sometimes it's helpful for you to know what helps you learn the most. So this message is specifically for our resident learners who are trying to figure out, okay, how can I learn the best? So there is also, in order to help us teach better, there's also the BID model. This is shown to be very effective in teaching in the operating room. I don't know if any of the attendings have heard of this or know about it, but it stands for brief, intraoperative, and debriefing. So just to move quickly through this specific model, this is the briefing is prior to a case. It's very similar to the timeout or surgical pause. Some attendings in my department, we not only do the surgical pause, but we also do an educational timeout, which can be helpful to say, okay, well, today, Dr. So-and-so is going to do this part of the case, and this is what we're going to focus on. Briefing is very learner focused, meaning that the resident can actually state what he or she would like to do in the case, especially if the attending has had previous experience with a trainee. And, it's a back and forth, and the attending can say, hey, okay, yeah, sure, you can do that. And then I will do this, or I expect you, since the last case you did this portion, I expect you to do this portion and additionally this portion of the case. This only takes a few minutes. Again, one of the things that we talked about in terms of teaching as a barrier is time, but this really only takes a few minutes. And it's suggested that the teacher focus on one or two learning goals. So what are some, intraoperative models that help with the BID model? So relating to teachers' teaching behaviors to actual acquisition of trainee skills is very scarce, especially in medical and surgical training. I wish I could give you best practices, but so far we don't have any, but there's some things that can hint at what may be effective teaching behaviors. So there was a systematic review by Icahn et al. On the technical skills in teaching medicine, sports, and music. And they found that feedback with instructions and suggestions for improvements improved specifically skills development. So this makes a lot of sense. Again, data from music, teaching music and sports. So what are some effective teaching behaviors that they found? So ask the trainee to verbalize their thoughts and their reasoning processes. Yes, we saw that in the 7 a.m. session when there was an open-ended question and the teacher allowed the trainee to just talk about what she was thinking about the situation and about the scan that they were looking at. It also gives you and the audience, the teacher, an opportunity to assess where they're at. Are they, do they know what they're talking about? Do they, and some other questions that you can ask during surgery is, what instrument do you want next? What's your next step? Why do you want to do that? Just very anticipatory questions to see and understand and assess if they have any learning gaps. Now, going back to a safe learning environment, if a resident is terrified of you, they may not answer you. So I recently had a PGY2 say in a kidding, kind of not kidding way that I can be intimidating, which I found very hilarious. but it was good feedback for me. So I assured him that I'm actually a really nice person and it's my job to make him a better doctor. And you can reassure them, this is not the oral boards. I want to hear an answer even when you're wrong, because at least this gives you a chance to correct them or ask them to go do further reading. And in this specific instance, it's okay to be wrong. So what other things can we do in the BID model, during the operation? So a quote by Benjamin Franklin, tell me and I forget, teach me and I may remember, involve me and I learn. So relating to teachers' behaviors involve your residents so as much as you can. They love to be hands-on, like mentioned before. And so what are some great questions to ask? So this is Bloom's taxonomy for thinking. And, you can imagine that questions that you can ask going from the bottom to the top range from very simple recall questions that, a medical student can answer about anatomy and location of, structures. And it can go increasingly in complexity up to the top of the pyramid where you expect good independent clinical judgment, which is what we expect from our chief residents and our fellows. So this is a great way to kind of think about, types of questions that you can ask your residents. And I thought, since I was going to be speaking to the neurosurgery group, I thought I'd look up some questions that could fall under these categories. So, an example of a recall question, which vessel, which is like an anatomy question, analysis, how would, this specific disease process present in this patient? An application, what blood product is most appropriate in a patient with von Willebrand's disease and a traumatic hemorrhage, and self-assessment. Let's say you came, a different type of patient came in, what would you do differently if faced with this situation again? So again, increasing in complexity, really trying to assess the learner and have them talk about, have them give an answer. So the last part is debriefing, probably done after the case is completed. For surgeons, it may happen when, while anesthesia is waking up the patient or after the patient is in recovery, and you can discuss how the case went and reflect whether or not your learning goals have been met. We all tend to be self-critical, and we all tend to focus on what went wrong, but that's fine for self-reflection. But for learners, we should provide them with specific feedback. So specific things we can talk about are strengths, weaknesses, suggestions, and solutions, and ask open-ended questions. What did you think of that case? Just open up the lines of communication. So now I'm going to talk about feedback. So feedback is always focused on what the trainee can do better in the future. It's formative, and it's an integral part of the learning experience, and allows the resident to stay on course towards the goal. This is in contrast to an evaluation, which is summative. So for example, how a summary of how the resident performed on a specific rotation. So in talking about feedback, I just wanted to mention this slide on generational differences in the workplace. A couple of years ago, this was presented at one of our national educational meetings, and I thought it was really interesting. So as you can see here, generational differences is the difference in behavior and outlook between groups of people who were born at different times. And this infographic is from Purdue University. So in medicine, it's the first time in history where there are 5 different generations in the workplace. And in the next slide, we'll see how the different generations view work. And that has an impact on how we view education and residency. As you can see here, the majority of the workforce are millennials. So I want to keep in mind that these are broad generalizations, and it may or may not be applicable to each of you, but my intention is not to offend anybody. I just wanted to point out that there may be some differences between educators and students in terms of values and behaviors. Most professors and chairpersons are probably in the boomers or Gen X category. They view work as something that's expected. Generation X, which is generation I'm a part of, love work-life balance. And millennials, where most of our residents are a part of, may see work as a means to an end. As we all know, times have certainly changed, and the expectations have changed as well. And getting to know our learners, most of whom are from the millennial generation, they prefer multiple learning styles, synchronous and asynchronous learning. They don't just like lectures and note-taking. They are technology natives. They dislike hierarchy. And a fun fact is 25% of millennials do not regard punctuality or attendance as a professional attribute, whereas faculty perceive lateness or not attending as rude. So culture is very, very important to them. I remember this when I think of the couches and snacks that they provide at, Google headquarters. They love multitasking, and I'm going to guess that their residents listening to this talk who are rounding and writing notes. And I know that's what my residents are doing, when they come to conferences. They are really very, they're multitaskers, they work strategically, and they rely on mentorship and feedback. So that's, again, going back to the importance of feedback. So our learners need feedback. Does anybody remember the feedback sandwich? Well, here it is in all its glory. We talked about it a lot in medical education, but now it's really not what we do anymore. So it used to be you say something positive, then you say something negative, and then you end with something positive. And it doesn't work for our new generation of learners. And it's actually quite confusing because you're giving kind of mixed signals. So my recommendation is we don't do this anymore. The new feedback sandwich is ask, tell, ask. So you ask the learner to assess their own performance. So for example, if you just finished a case with somebody, you can say, how did you think you did? Were you comfortable with suturing? Were you able to manipulate the cystoscope as you wanted to? Did you think that you finished that in time? So it's great because it begins a conversation, it assesses what the learner thinks of themselves, and it promotes reflective practice. Then you tell them what you observed as an attending. You can say, you know what, it looked like you weren't very comfortable with the cystoscope. You were kind of struggling putting it together. Maybe we should go back and review what the pieces are and how can I help you to be more efficient. Telling them also helps normalize feedback. Use very descriptive language, be specific, and avoid generalizations. And then the last part is, ask them to repeat, clarify, and confirm what you just told them. So again, ask, tell, ask. My quick example is Josh was one of my second years, and he was closing skin, and it looked like he really needed to practice how to tie the knot single-handedly. And I gave him something very specific to think about. I said, try to remember to push the knot all the way down with your finger. Make sure you're doing square knots. Again, so that's specific to him. It's timely. It's right after the case. And, I'll send you some videos. There's some great videos online about how to, to see how you can figure out how to tie knots better. And again, for asynchronous learning. So he can go home and in the comfort of his own home, review a video. And you can ask him also, repeat and clarify, okay, is there anything else that you had a struggle? You felt like you struggled with? Any other questions? And that really opens up, again, the conversation. So this was a very fun infographic on 4 suggestions on how to give feedback, be specific, be sincere, offer help, and of course, be timely. But not to be outdone, this is a group from Britain, Lafoy et al., who reviewed the entire medical education literature. And they put together 32 guidelines. I'm not going to go through all 32 guidelines with you, but they divided their recommendations into strong, moderate, and weak, similar to how we evaluate any journal article or piece of literature. So strong is defined as a large and consistent body of evidence. So what did they find in their review? So feedback is, again, extremely important. And it should be recognized that there are many influences to feedback, which include culture, values, expectations, personal histories, relationships, and power. Just like I mentioned, it has to be specific to the trainee, reinforce what was done well, identify what was left out or omitted, and what can be done better, and come up with ideas on how to improve. Don't say read more, you have to be more specific. Another aspect that I wanted to mention is the importance of non-technical skills, again, which is a whole talk in and of itself. And some examples of non-technical skills are listed here: effective communication, teamwork, coordination, leadership, situational awareness, clinical decision-making, and coping with stressful situations. And adverse events in surgery, as we all know, are not so much caused by deficiencies and errors in technical skill, but rather by deficiencies in non-technical team and communication skills. So I wanted to be sure that that wasn't omitted, because that's a very important part of resident education as well. So here's a summary of effective feedback: sharing goals, make sure it's well-timed and expected, an appropriate interpersonal climate and location, so that's optimizing the learning environment, based on firsthand observations, stay away from generalizations and be very specific. Try to discuss behaviors that are remediable. So not that, okay, maybe Vannita, you need to be a little taller. Like that's not remediable. And one of my attendings actually jokingly was like, Vannita, when I was helping him in surgery, you need to grow a third arm, because I was retracting everything, and we just wished I had a third arm, but that's not something I can do. So be very descriptive and non-judgmental. Focus the feedback on decisions and actions. Don't assume thoughts or judgments or anything internal. It's best done in small portions, and of course, include suggestions for improvement. So here it is in a nutshell. I know I talked about a lot of different things. And this is the THM, or the take-home message. So for residents who are listening, like I said before, this is probably the only slide you'll need to know. Residency goes by fast, and I hope you enjoy every minute of it. Try to look at this learning cycle, and it's basically, operating, getting in there, learning the surgical techniques, reflect on the experience, try to think about what you could do better. Abstract conceptualization is, reading and thinking about, what had just happened. Active experimentation, going out and planning your next experience and then doing it again. So attending, I have 2 words for you. Give feedback, because our learners need it, they want it, and it's important for them in order to develop further as surgeons in their career. I have something for leadership and chairs, the leadership and chairs who are listening to my talk. I gave a lot of examples of barriers to learning. If any of those barriers are things that you can help mitigate, it will go a long way in supporting your teachers and your learners. And that means establishing a positive learning climate in your department. And again, I was very impressed by the first session this morning. I thought it was a very wonderful, positive learning climate. Residents were able to ask questions, very thoughtful questions. There were great pictures. I thought it was wonderful. So to put in a plug for the GME office, again, remember, I don't have any financial disclosures or anything like that, but I really do love faculty development, especially in education. There's lots of great programs here at Sinai. There's also, if you're not interested in the ones here, there's professional societies which offer educational workshops, and also the ACGME, which I had the pleasure of giving a talk to this past year, is also a great resource. It's great to hear from different institutions, from different departments, to see and hear what they're doing, because it inspires you to do wonderful things and bring it back to your own department. So excellence demands effort and planned, deliberate practice of increasing difficulty. We must continually challenge ourselves as educators and push our learners to the next level. This not only applies to neurology, neurosurgery, urology, but also to medical education. Some of you may be familiar with Anders Ericsson. He's a Swedish cognitive psychologist who wrote Peak. And this book was based on his 30-year experience on how to acquire expertise. So Ericsson talks about getting out of your comfort zone and putting deliberate effort and practice with increasing difficulty. You can stay doing your everyday skills, or you can push yourself out of your comfort zone and become more of an expert in what you do, whether it be in neurosurgery, education, or urology. We want to push our learners out of their comfort zone as well. It's our duty as educators to help them get where they need to be, which is outstanding physicians and surgeons. So I want to thank everybody for inviting me to speak to you today. I know it's a different context because it's Zoom, and I probably would have paused a little more and asked to hear thoughts from the audience, which I always love doing. And I love, looking at learners and, looking at the audience, but, there are some limitations to Zoom. But I would love feedback on my talk, because I want to know how I can get better. And I did this talk, or I did a similar talk 2 years ago. And the feedback that I got was, you need to put more pictures. So I don't know if I went overboard or put too many pictures, but I hope that everybody got a little something out of my talk. And of course, I'd love to hear questions and comments. Thank you.
While people are thinking about their questions, I'll lead off with one. As a department, we've talked recently about, what training our residents is and how we can make it better. And one of the barriers that some faculty members have brought up is the concept of fear and emotion in the high stakes field that we all work in, and how that can interfere with both teaching and learning for residents. Do you have any comments on how to combat that in those moments in terms of contemporaneous feedback versus delayed feedback or other strategies?
I think that definitely for your specialty, you're probably faced with more life and death situations than I personally have, as a field in urology. I think that when, for example, in a trauma situation, I think just very simply saying, you know what, this is going to be a tough situation. And, if you're going to have a resident with you, a chief resident, a learner, a medical student with them, I think, the BID model is really great, with the exception of maybe not setting the expectation that, you're going to observe. You're going to watch what I do, or try to watch and absorb everything I do now in this trauma situation. And the next time we can involve you. I think I mentioned that in my talk a little bit with respect and comfort. If you're going to, and it's not intentional. And I think that once you express that to med students, residents, they understand, okay, I'm here to watch. This patient is the priority. There's an emergency right now that I have to tend to. Then you can have hopefully a debrief session afterwards and say, hey, that was a really tough case. Let me just review and go over what I did in this situation. And maybe there are other modalities that are not as urgent and that have to be tended to. I hope I answered your question. So debriefing it can be just as effective as well.
Hey, Vannita, Costa Sajapanizer, really wonderful talk. Thank you for spending this hour with us. I think it's such an important topic and timely. Piggybacking on what Peter just discussed, we are in situations where we're doing, various complex things. And, when you look back at your residency, some of the things that were branded in your brain the most were off complications that occurred in the OR, where you said, oh my gosh, I'm never going to do that again. And then, you kind of witnessed it and expected. And I wanted to get your thoughts on that. In a complication or a difficult situation, we sometimes we get emotional. All of us do. I mean, I can't think of one person who doesn't. And what I try to do is I try not to reflect that on the resident, but sometimes it happens, and it just happens because of what we're doing. And I'd love to hear your thoughts on this. I mean, I like the case of delayed feedback, but I feel like immediate feedback is important as well in those situations, because it really helps that kind of crystallize in their brain what's going on and how to do things better.
I agree with you wholeheartedly. I think that any type of communication is needed. I think that when it's emotional, you can say, you know what, that was tough, and you don't have to get into it now, or you can say, let's talk about this later. For urology, some of our M&Ms are very emotional, and when we hear about a death of a patient, it's very hard on everybody. But I think that it's important to talk about it, whether it be right after the case. I think both parties, want to be sensitive to how you're feeling. You don't want to push yourself and say something when you're not ready, but you can always table it and say, you know what, that was tough, and let's take some time and dedicate another safe space time to talk about it when it is appropriate. Again, I'm sorry, I'm making kind of broad generalizations, but I think that not talking about it is probably more damaging in the long run. And that goes back to establishing a safe space where you can talk about things, and it's okay. It's okay to be wrong. People make mistakes. Even the best surgeons make surgical mistakes, and that's something we don't want to hear sometimes, but that's the reality of it. Even the best of us make some mistakes, but the important thing is we learn from them, and we take those moments and use it for better care for the next patient that comes in. And I think those are very, very important things that, both of you have brought up and touched upon.
I would like to thank you for this wonderful talk as well. It's really eye-opener and really timely. Is it possible to get some feedback from the residents? We had some pretty hairy things happen yesterday that could be fit into your talk. Trevor, you have any comments on what you heard today and what you experienced in the past few days?
Yes, sir. I mean, I think one of the things that was good for me to see as a observer yesterday from that educational perspective of not being scrubbed into the field, but witnessing, a complication, was observing, how to manage something that, could be extremely hazardous to a patient. Assessing the situation, remaining calm, which, even from my standpoint, not being scrubbed in was not easy to do, let alone, I'm sure, being scrubbed in and assisting with the complication. So I think that was one of the things that stood out to me, aside from the technical aspects of addressing the surgical issue, was really just the management of the room, management of the personnel and the situation at hand.
How about you, Travis?
I think what I learned from that yesterday was there's phases to management of intraoperative complications. There's making sure you have the right equipment, personnel, staying stone cold focused, and debriefing after.
Thank you.
If I can also comment, Vannita, it's an excellent talk, and it's a topic that we talk about all the time. Traditional model was a lot of passive learning where you did many hours and you stayed and you watched hundreds of thousands, maybe cases. Now with restrictions on time, it requires a very active learner model where residents have to be prepared. Essentially, they have to read, they have to prepare, they have to do this on their own time. How do you guys in urology address this issue with limited hours and preparation and making sure there's an active component to this?
I think that we're all struggling, medicine, not just urology. Again, I mentioned that I went to the ACGME conference and I'm involved in GME here, and it is a system-wide, not just our institution, but other institutions are struggling because of the limited work hours. And as myself and many of the chairpersons, professors, assistant professors who are on this webinar, we didn't have work hours, we didn't have duty hours, we worked all the time, we observed a lot. There was so much time for us to absorb and do things. We had bigger surgeries. Now we have shorter surgeries. All of those barriers that I talked about are real. And the way to combat this is just be very intentional with teaching. We have to be. And like I mentioned before, there's competing, there's competing things for our time. And we have to, with EMR, again, patient volume, we have to write, we have to publish, we have to do research. It's getting really, so we are not, if it makes anybody on this call feel any better, you are not alone. We are not alone. It's happening all over the country. And the answer to that is to try to be more efficient with teaching, give better feedback, provide our learners with the environment for them to be able to ask questions, to be able to, identify what is it that I'm not getting, what is it that I'm missing, so that we can readily address those. So, for example, we had a resident who, wasn't doing well on their in-service, and it's not something that we can just say, okay, whatever, just go study more. We have to be very active and intentional. We have to make sure that that resident gets the foundational knowledge that they need to pass their boards, right? On top of the technical skill, they need the knowledge base. So the real emphasis in medical education is to be very intentional. And again, I think having, when I saw that you had, the chairman's chat in the beginning, even though it didn't happen today, I thought that was very lovely. I think it's great to check in with your department to see what the gaps are and see what the needs are, and for leadership and, chairpersons to fill those gaps and to have us understand, okay, what is the landscape, like I mentioned, has changed so much for medicine, and we have to, as academic surgeons, we have to respond. So I think that this is a first step. My 1 hour talk may not change anything, but at least it helps bring up conversation. And I hope that the conversation continues. And the bottom line is the conversation has to continue, right? It has to, or else we will lose a lot of important educational moments for our residents.
Vannita, one thing I wanted to also add as a side effect or an evolution of not only work hours, but as you mentioned, the increased volume, is a transition from an almost completely resident-run service to a service that is now a team that includes many different types of people, at which you alluded to during your talk. We have 14 residents. That's 2 years. So, 7 years, 2 residents, 14 total. That's not nearly enough to care for what we're doing with our 5,000-6,000 cases each year. And what has evolved is an amazing APP service with over 120, almost 130 APPs who are integral part of this. Leslie Schlachter is our chief PA, and I'm sure she has some questions or comments on this. Could we ask Leslie to ask a question or comment, please?
Just a second.
Thanks, Chris. Chris is promoting her so she can be a panelist.
Thanks for letting me in. Thanks for keeping this conversation going in our department. Yeah, I actually, it's interesting because in medicine, no matter what you try and do about it, there's always going to be a hierarchy, right? And so I talk about this often with Dr. Betterson and other doctors, that there's the attending effect, just like you said, you had a resident, you couldn't believe it, that was afraid of you. So there's the attending effect, and for APPs and Ps and PAs, there is sometimes, the resident effect. So there's all of these little nuances that can make learning difficult at times. So my question is, when we're in an operating room at this academic institution, there's often, an attending, or sometimes a chief resident, a junior resident, maybe a PA in the room. What is the best way to manage communication at that time? Like, maybe there are times that there's a PA that's been around for a while that sees something happening, but is afraid of bringing it up to a chief resident, or, a resident that I can see squirming in their chair that wants to say something to the attending. It can be very nerve-wracking.
Yeah, I agree. It can
and so
be.
I guess my question, I buried it in there. So bringing up this whole conversation of proper communication and education hopefully links into opening up the doors of communication to feel free to speak freely. But what are your thoughts on looping in that hierarchy with communication?
I think that, communication, I think if you ground it in patient safety, I think that, again, I don't know, and I don't know the specific situation that you're talking about, but obviously if it's a low stakes situation where you want to say something, then, you can probably save it for later. But if it's a high stakes situation where a patient can get hurt or get injured, I definitely would want somebody to speak up, whether it be a medical student, a chief resident, whoever it is. We all should feel comfortable with speaking up if it comes to it's a patient safety issue, and there shouldn't be a hierarchical issue there. That to me is my perspective. I think that patient safety is number one. We're all physicians, doctors, advanced care practitioners, and our goal is to keep patients safe, right? And again, I don't know the specifics of your situation, but I would say you have to just bring it up in a respectful way. Say, I'm concerned that something is not going right with this specific situation. I don't know if that helps, but I think grounding it in patient safety that's the shared goal that all of you have, right? You're not there to, we're not here to hurt patients. We're here to help patients.
We've got 2 more minutes. I just wanted to call on Dr. Tanvir Chowdhury, who has a comment.
Thank you. First of all, enjoyed your talk tremendously. Obviously, our department's very focused on this. My question would be interested in your comments on 2 things. One is, some of us, including myself, most importantly, have been working on transforming our clinical education style. Even though I've been doing it for 2 decades, I've gone through various epics in my own thing and certain deficiencies I'm working on. And I guess my question is, do you have any comments on people themselves trying to change, and whether you think people can change effectively on that? And then the second part is, in a group, let's say we have 6 people in a subspecialty like spine or something, does everyone tend to need to do all things in the education, or do you sometimes see it possible for certain people to have, some educational styles are operating with the resident, and sometimes it's having them operate independently with less hands-on? And do you feel that people should kind of use the whole gamut, or is it possible for different people in a subspecialty to focus on education, different parts of it?
I think it's possible. Again, I don't know the specifics of your department, but I can say for my department, there are certain surgeons who are just natural teachers who just, without any formal training or anything, they're just really great. They let the residents do things. Other attendings don't let the residents operate, and that is kind of a thorn in the side. But we have to also respect my colleagues' practice, right? Maybe they're technical things that they want to do and they don't want the resident to do. But the way that they counter that is they do conferences. So again, there's lots of different ways to teach. Maybe I mentioned in the beginning that, there are physician-related barriers. Maybe some surgeons can't teach or aren't unable to teach because that's just not the way they're trained and that's not the way they communicate. And I think that's okay. I think that there are different ways to teach. You can observe, you can reflect. You don't have to let in order to be a good teacher, it's not like you have to let the resident do the entire case. That's not the hallmark of a great teacher. I think that there's different ways to provide wonderful environments for education. Another attending does simulation. So he dedicates a whole day, invites the residents, and they operate on inanimate objects with the robot. And I think that's another component of education that I didn't specifically talk about. But there's lots of different ways to be involved in education. You don't have to, just like each surgeon, not everybody has to be the same.
I wanted to give Ray also a chance to comment.
Oh, great. Thanks. Yeah. Really great talk. And just wanted to kind of just echo your sentiment, about feedback. We found in our own kind of program in terms of looking at this over the last 4 years, that feedback, attendings giving feedback to residents has really been one of the determinants of faculty, getting sort of improved performance evaluations on how they're teaching, how they're mentoring residents in our department. And one thing that I think I will be talking about a little bit more in one of our future talks, but that we may be kind of struggling with now that we've kind of instituted this program, is kind of the reverse, and how residents and other trainees can be giving feedback to the attendings on how they're doing in terms of providing educational needs of the residents. I'm just wondering, in urology, have you encountered this? Do you have any advice or a way that residents and trainees are encouraged to provide this feedback to attendings to improve performance in teaching?
Yeah, I wish our department had something more formal. It's very informal. Usually our chairman will ask whenever he has these fireside chats with residents, who are the good attendings and who do you want to be in the operating room with? And everybody kind of knows who it is. But there's no formal evaluation form. I kind of wish there was. There's pros and cons to that approach as well, right? So there's the informal, where you kind of know who's a good teacher. All the chief residents want to operate with this particular attending and kind of shy away from another attending's room. So those are kind of some informal ways. I wish that we had something more formalized. I agree with you. I think feedback for faculty is extremely important. The other thing I want to mention is their teaching awards. And this year I'm starting to give out mentorship awards. And I think that is good feedback for the faculty who are doing the right things. And again, I think it goes back to establishing not only an optimal learning climate, but also encouraging that climate and rewarding the good behaviors of your attendings and highlighting them. And for those who want to seek out more, skills and more education on how to be better teachers, allowing that to happen, giving, faculty time to go to these conferences and go to these workshops. I think it's multifactorial.
Thank you.
Well, that was fantastic. I'm going to offer that Ray Young gives a grand rounds to your department on his now published and extensive